there, my name is Dr. Kim Ernest. I'm a licensed psychologist, licensed professional counselor here in the state of Pennsylvania, the president of Pennsylvania Counseling Services, the founder of Live Up Counseling, and today we are here on the How to Be Happy Hour to talk about Therapy 101, all the different things that we wish we as early career clinicians would have known entering into the field.
I'm Coral Lively. I'm a family-based mental health professional.
I'm Eden Yonner. I'm a forensic outpatient therapist and developmental supervisor.
I'm Sarah Horst. I'm a licensed professional counselor.
I'm Andrea Lonick. I'm an outpatient therapist.
So today I want to start us off in sort of a slightly different space. And I want you to imagine if y'all had like a TARDIS or some other less cool time machine, and you could go back and meet yourself on day one in this field, in this career. And for some of us, like that day one, we can remember like the first day on a job, or we might recall like walking into university or whatever that is. If you could go back to whatever you would define as your origin within the field, what advice would you give that version of yourself? Or what are some things that you wish that person knew as they undertake this life-changing career, this professional decision that's going to change you along the way? So what are some things you wish that guy knew?
That it is not your job to rescue everybody. I think that was, and it's something I still struggle with. I definitely have like a protective side, but I think when I went into this profession, I was like, every single family I'm working with, like every single one's going to feel better about themselves. The kids aren't going to hurt themselves. And I've had experiences where kids went back to inpatient, went back to RTF, and I beat myself up over it. So I definitely would think, don't feel like you need to rescue everybody because it's impossible.
Yeah, I think building off of that, I think one of the things I struggled with understanding and really learning was how progression within like a client's therapeutic journey should happen. And so I would often find myself like pushing a lot harder for things than I needed to. So I think in some way addressing that, or just that it, to take it slow.
Patience.
Yes.
No, it makes me like those video, we were talking before we got started about one, but those videos, those therapy tapes you watch in grad school of like the perfect therapy session, and they're all amazing. And it's like the theorist who comes in and the client does everything they're supposed to do and the therapist does everything they're supposed to do. And it's like this, and I feel like those do a lot of disservice because I think that really messes with our perceptions of pacing. You think every session needs to be one of those like, sessions, and they're just not like, you're going to have sessions that don't have those amazing aha moments.
Well, and I think for like early clinicians, one of the things that a lot of people really look for is some like step-by-step guide to like implement some sort of theory with a client so that they know what they're supposed to be looking for. This means I'm doing this correctly, right? And I think that's really difficult because people are so different. The dynamics in their relationships are very different. And so molding it to each person is kind of its own unique thing. And I think for that reason, it can kind of be a disservice when you're reading step-by-step instructions and asking yourself why you're not receiving the same progress that you're reading about, why it's not happening like what you think it should be. I think that can be difficult for a lot of people. It was difficult for me. So.
Yeah.
I found myself like cramming a lot when I first started an outpatient. Like, I have to learn this modality or this intervention and I have to execute it perfectly. And if I don't, then not good enough, right? And that's just not how change works. So,
yeah, I think it almost became more of like a performance than it was like a therapeutic session. Like I needed to know the steps to the dance in order to effectively engage with the client. And I think there's validity in like, you do need to know things and knowledge is important, but I think it's a lot less scripted, right? It shouldn't be scripted.
I think knowledge, and I think to use a theory is essential.
Yeah.
But you don't need to know the theory perfectly. Like, it's a striving, it's a journey, you know what I mean? Like, I think that's the cool, like, we're not basketball players, right? Like, our careers aren't going to peak at 36, or not peak, I guess that's like the end of a basketball player's career, but you know what I'm saying? Like, we will only be able to deepen our practice and become stronger and more effective providers over the course of our lifespan and careers. But you need a theory. And I think so often I do a lot of interviews right now and I'm like, hey, what's your theoretical orientation? Like, I'm eclectic. I'm like, eclectic meaning you draw from what? And they're like, oh, eclectic, just whatever. And it's like, no, that's not the. There are no wrong answers to that question, but there is one, and it is, I have no theory. I just do whatever I want to do in the moment. I think that's dangerous. I think that's risky for sustainability of the provider. I think that's hard for the client, unpredictable. There's not that thread of continuity, but you don't need to know it frontwards, backwards, and perfectly execute every single time.
Well, and I think having some sort of theoretical background, you begin to like get to see it and play the more clients you work. So you'll gain a greater understanding the more you attempt to implement it. And I think that honestly, I think being eclectic is good. As therapists, I think taking from your experiences working with clients is good, but it's having that background that I think strengthens you as a clinician. So there's also a piece of this that's just time and your own therapeutic professional journey. I think that will help people build in confidence and whatnot too. So,
well, and I think too, as long as you're basing your interventions out of that theory, having the courage to say the things that you think need to be said. I am an overthinker. And so if I could go back and talk to myself and be like, stop thinking and just say it.
Say the thing.
You know, like just like it's okay to guess wrong as long as you're within that context of the model.
Yeah.
But if you're, trust the model and go for it and don't just get in your head all the time, because then you're just sitting there and they're just talking at you. And
When
that
you're
can
not
have its
present.
place, but yeah, you're not present, you're not engaging, you're not, because it's like, okay, what do I say next? And like, well, how's that going to be received? Well, I don't want to say it like that, but I want to say it like that, So I know for myself, like that was a lot of the work that I did early on was like, how do I just say the stuff that's going on in my head? Because I got good stuff going on, like it's all based in the theory. How do I say it?
But do you like stay there too long? And then
Early
the
on,
moment, yeah, and then
absolutely.
the moment's passed, right? Like I remember those.
And then all of a sudden it's like, oh, we're at the 38 mark. I should start wrapping up. I haven't really said much. I should probably say something to maybe summarize and send them on their way. Better luck next time.
But we need those, right? Like
Yeah.
you're going to have those moments. But I mean, I recall those moments early on. And I don't suffer from the affliction where I think things and don't say them. That's not one of my big problems. But I relate to the piece of being too in your head that you're missing what's happening in the room.
Yeah.
And I would say that's happened to me a lot. It still happens. I was driving in here this morning. Right now, I am navigating now it's more personnel issues that always tap in, but right now navigating a really, really nuanced and difficult personnel experience. And the very first thing I said to the person I'm talking to is we're trying to figure out what the fuck are we going to do with this? I was like, we got a pickle on our hands and this is all the layers of nuance. But there's no way for us to get out the other side. And we both had to sit there in that moment and name, like, we are scared going into this space and we're going to do it together. And it's somebody I don't work with much. So it's kind of like that weird, it's a little different when it's somebody I know, like I've worked with Eden now for like 4 years.
Yeah.
So I know Eden pretty well. Like I feel like he and I can walk into a scenario and I find Eden not predictable in a bad way, but I can kind of predict your style. I think we have some layers to our relationship that feels safer. But especially when it's like novel, unique, and hard, there are moments where I'm like, I'm not even here anymore. I've now gone into this imagined apocalyptic future, and I don't know how to get us back out of it.
This is somewhat related to what you're talking about. When I'm doing developmental supervision with new therapists who come into the practice who don't really have therapeutic experience, I think that's something that I've heard get talked about before, is just not exactly knowing both who they can turn to for, assistance and support, but also because of the ways in which other facilities and just places they may have worked, how supervision, how, management works, they don't necessarily want to go to somebody and talk about things that they're struggling with. And so that being just a very difficult process to begin asking questions and begin to say, I don't really know what to do. Because oftentimes, again, we want to present ourselves as knowledgeable and capable. And so I think that can be very difficult for newer people as well. And I don't know that that was necessarily difficult for me, but I think that finding out who I know that I can talk to and who is safe and, reliable, those kind of things, I think that's difficult for a lot of newer.
No, I think this, you talked about the performance of therapy. And I would say as a supervisor, I see more of the performance in the supervisory room at times.
Yeah.
And that's so tough and I get it, right? Like positive presentation management, it makes sense. It's totally normal that this person that's going to send all these important papers to the state for me in a couple of months, like a couple of years, like of course I want to leave a positive impression.
Yeah.
And it impedes the ability to get the most out of supervision. And so it's a weird, I guess I would have gone back in time and told myself, your supervisors love you. It's okay. All of you. They love all of you. They love the parts of you that stay up until 3 a.m. obsessing about what to do next. They love the impulsive pieces. They love the weird fucking facial expressions you make in therapy. Like, do it all. They love all of you. Bring it all into supervision and look at it, create space.
I think I see the most of it in regards to like administrative, like clinical documentation, that kind of thing, because I feel like within, oftentimes people will become comfortable at least talking about what they're doing with a client, the work they're doing. But then if they're struggling with completing documentation, struggling with managing their schedule, that stuff, a lot of people feel a little bit more shame or guilt regarding not being able to handle as well. And so they'll hide that. And so I think that can often be something that, just asking about, it can be difficult for a lot of the newer people, at least in my experience that I've worked with. So
I think the biggest thing with supervision, and I had to learn this pretty early on, is that you need to show up like exactly as you are and be willing to be vulnerable, whether that is in the individual space or even in your treatment team meetings, to say like, this is really difficult for me. I feel like I should have this figured out and I don't. And when I've had those conversations, I've never been met with anything but love. And supervision's like a space to kind of, to have this issue that maybe we're not seeing brought to light. And it can be really like career changing, honestly. Like when you're forced to like look at your own shit and consider like, how is this going to impact the work that you're doing? And then you take action, right? Because you value your career, you value your clients, so then you take that committed action towards helping them. And life's just great when you're vulnerable.
Life is great when you're vulnerable. New title of the podcast. Life is great when you're vulnerable. Yeah, no, I agree. I see a lot of really career clinicians really struggle in that space, or they struggle with, I think another big one is like countertransference.
Yes.
Like I feel something about my clients, and that's weird. And it's totally normal. Hear this. It's very normal to feel feelings about your clients, all kinds of feelings, happy feelings, sad feelings, angry feelings, frustrated feelings, annoyed feelings, hopeless feelings, helpless feelings, scared feelings, like attraction. You can be attracted to your clients, all normal. Don't act on it, address it, but all normal. And I think that's the I think early on you go in, and I think our grad programs, and it's been a long time since I've been in grad school. I think maybe some of y'all got out a little bit more quick or a little bit more recently than I did. And maybe it's shifted a little. But there's a lot of attention paid to like theory and practice and even like best documentation, dynamic, do all this stuff. But there's not as much attention paid to like you as a person doing the stuff.
Yes.
And I mean, I get it. That's hard to do. How do you operationalize that in a classroom of 30 people? I don't know, but
I
you got to find a better way.
that.
What?
I went, my graduate program, Harry Ep8 was one of the professors.
Oh, wow. I mean,
And so we had person of the therapist class the whole first year. And it was amazing.
so jealous.
I know, it was terrible, but in a really good way.
yeah.
Because it was like, so they put smaller class sizes. So then, and it was him and then one of the other professors co-facilitated. And then
I'm so
the
jealous.
whole first trimester was you have to figure out what your main personal therapist issue is and write a little paper about it and bring your genogram. And then you would present it in front of like your smaller group of classmates and these two professors. And Harry would just pretty much like emotionally dissect you and leave all of your emotional organs on the table.
And then
like, okay, that was a good session today, and off they would go.
This now.
And then your classmates would come around you and be like, okay, we understand. Like, you know, like, so it was like a great experience, but also so hard. And then the different semesters built on each other of like, how do you recognize it when it's in the room? How do you now work with it when it's in the room, and not just like, oh, it's there, I'm going to put it on this shelf so it doesn't impact this, but also how do you work with it?
I knew it, like here at PA counseling, we have a POTS group. So you facilitate one of them, don't you? So we have the POTS group where all of our early outpatient therapists participate, is it twice a month? In like what's getting stirred up for you, what's this looking like for you, and there's a lot of that. But not all of our programs have that. Family-based obviously has heavy pieces built in.
Yeah, it kind of comes out in your supervision. There's a lot of stuff going on
there. But I don't know how many or how common it is for community mental health agencies to attend quite so fully to POTS. I know in my training experiences, I did not get as much of that as I would have liked or would have been beneficial to me.
Yeah, so I was kind of surprised because that was my experience. So like, wait, what? All the graduate programs don't do that.
I think that's a very unique experience too.
Yeah.
You went to UPenn?
Drexel.
Drexel. So I knew you were Philadelphia somewhere.
Yeah.
Yeah. I don't know. Did y'all have anything like that in your programs?
We had a course. Yeah.
You had
It didn't sound that great, but we did.
Well, it wasn't Area Ponte, so there's.
Yeah, we made genograms and we would have to present them and things of that nature. So we had some prep.
Good.
I don't think anything's it's not the same as the real thing.
Nothing will prepare you for it.
Yeah, unless you go to Drexel.
Unless you go to Drexel. But even then, did it prepare you fully?
No, I still had no idea what I was doing in general. I was still figuring myself out.
As many of us are, right? Like, it's not abnormal. I don't know. I didn't have anything that great. We had our group therapy course was group therapy. So we came in, we all did group therapy.
That would have been helpful.
And so we each took turns facilitating group of our peers. It was a great way to learn. But there isn't as much of that. Like, even now, I go to a lot of trainings, and the experiential pieces there's not a ton.
That would have been like the most helpful piece. I don't think like in grad school, maybe we just did some role plays. We practiced CBT with each other. And that was about it. Like, my program was very like foundational. And then you get in the field and it's like, how do I navigate this mandated client that I'm about to piss off? It would have been really great to have practice
with those things. Yeah.
I think the role plays may add to that whole scripted performance thing that I talked about earlier, because you prepare for it, right? This is what I'm going to say. This is what I'm going to do. And this is my character in the group. And this is what I'm going to do and say. And yeah, I think so it can take away from the like genuine or authenticity of a real group. And right, you can't act out resistance in the way that people actually experience and express, anger towards you and things of that nature.
Deb Thomas, one of my favorite humans here at PCS. I just think she's great. But Deb has been on the pod before talking about Krav Maga. That's her big thing. And when you train with Deb or any of her group for Krav, which I have, they will punch you. They actually punch you. I didn't know that going into the space, but no, they will beat the shit out of you. Like, you have pads, but it's all designed to help you take a hit, because Krav Maga is designed to help you stay alive in a situation in which someone intends you harm, stay alive and get out of the situation. And many of us, if we're lucky, we've never had to take a hit, or we've never been in a scenario where we get in. So the whole idea is that this is going to happen. It's going to ring your bell, and we need you to be able to respond if it does without kind of getting too up in your head. And I think with psychotherapy, I see a lot of parallels there. Like, if we you have the role play. Yeah, maybe the client will yell at you or whatever in the role play. But I know if you're playing an angry client, it's unlikely you're going to stand up and lord over me and posture and scream in my face and spit on me, or worst case scenario, hurt me. Yeah. And with I mean, I've had client situations where I've not been as confident. I've had client situations where I'm sitting there and I'm like, this dude could fuck me up, and I'm not sure he's not going to. And I have to like stay in my body. I've got to like pull down the noise and not make a bad situation worse. And there's no role play that prepares you for that moment.
In working with forensic clients, especially people who've committed violent offenses and have spent years in prison and things like that, one of the scary things that some of the people have talked to me about is just the fact that even though the furniture is positioned in a way that will help you leave the room quickly, right, and you have a button to press, and there's several feet of space that if somebody really intended to hurt you, they potentially could, and that's scary for a lot of people. It's never happened.
Yeah.
But yeah, like you were saying, in the role play, you know your classmate's not going to do that. But then you're sitting with a real person, and all of these other possibilities open up, and I think that's scary for a lot of people.
Yeah. No, and I think, so that's another thing I'd like to go back and tell myself on day one, is that you'll probably be safe most of the time. And I think that I navigate that a lot. I'm sure you did in family-based, or because you go into homes, you went into homes, you went into homes.
I think that feels different when you're going into
it feels
somebody's
different
home
when you're
versus
going
in
into
the
homes.
office.
I've had some stories.
Yeah.
Yeah, I mean, it's since starting in family base in 2020, I swear these kids are upping the ante.
Yeah.
Like I've had a kid throw a pack of water bottles in my face. My partner and I had to barricade behind a door because this kid's like, I'm going to kill you. And I'm calling my supervisor going, hey, I'm calm, but there is a kid like half of my size threatening to kill me right now. I've had a kid like try to attack my partner and I while we're driving, like throwing stuff. I mean, it's police involvement. It's crazy. I was not prepared for this.
Yeah.
I don't think any class in grad school can prepare you for a child attacking you. I mean, like that's like, because, you know, it's different with adults when kids are coming after you. Like, you do not, like, you shouldn't be touching anybody, period. But it's like, what do I do when this kid is like literally like hurting me? This kid can throw a punch. So, yeah, definitely that'd probably be another life lesson, is just because you're in like what we call like a safe space in a room doesn't mean that it's not going to be, you know, safe always. So that's probably another lesson I would tell myself, is be prepared for the unexpected.
Be smart.
Yeah.
Be smart about it.
Yeah.
No, I think that's very valid. And I mean, I've done this work a long time now. I've worked with a lot of folks that have done some pretty violent things. I worked within the walls of prisons a long 12 years, a long time. I mean, I spent a lot of time in institutions working with people who have done some pretty violent things, or in the community working with people who have done some violent things. And I've only had one client try to hit me my whole career. That was on a hospice. It was of all the places.
It's the only place I've been swung at, too. So.
Really, on a hospice unit? Yeah, so there you go, kids. Yep. If you've started at a hospice facility recently, but it was on a hospice unit, and this gentleman wanted to leave and meandered towards the highway, and I didn't know what to do, so I stood in front of him. And he told me what he thought of that plan. So I think that's like also part of, like, you can have some pretty, I think there's a sacredness to the therapeutic relationship that even when they're mad at you, and not to say that horrific things don't happen, they sure do sometimes. But I think there is a line or a boundary with many of our clients, maybe our kiddos less so. But I know with adults, I've never felt terribly unsafe. And I'm sure a lot of people aren't thinking like, well, that 7-year-old's going to be the one that like terrifies you. But like, it's usually.
It's a scary, because when it's more of not being scared for myself, being scared for this child in the world. Like if he does not get the help he needs, like what is going to happen when he's 27? Yeah. So that's more of I'm thinking about their future more than anything.
Your own safety.
Yeah, and maybe this doesn't apply for if I'm going into somebody's home, but maybe one of the things I might tell early, clinician myself, is that most clients don't wake up in the morning and think, I want to go fight this therapist in his office today.
I'm sure I've had a few, but No, I think that there's a lot of validity to that. And I think, I mean, the big thing that we work on at our family-based mental health services training center is supporting clinicians in what to do in that moment. And we want to teach you the model. We want to help you become effective at like joining and doing all the different assessments and reframing, thinking systemically. We want to support you in doing enactments and anchoring your work, and all of that's extremely important in family-based. But one of our big focuses this next year is going to be, how do you maintain your own wellness in the process? And I've always said that, like, if you don't know what to do in therapy, do two things. Like, take a few breaths, get back into your body, and then get curious. And if you can do those two things, it's very unlikely you'll do harm, and you'll probably do some good along the way. But I think so often we just get dysregulated and we lose touch with ourselves. Mm-hmm. When it comes to the early career process, what are some ethical or boundary-based components? Because I'm sure we all had an ethics class, right? Mm-hmm. Yes. So we didn't all have a person of the therapist class, only Sarah. But we all had to do an ethics class. What are some of the ethical or more boundary-based pieces that maybe weren't necessarily addressed in that ethics code that we were for? I had to memorize the ethics code. I don't know what y'all had to do, but I had to like literally sit down and memorize like what was 13.A or this or that. I couldn't do it now, but we had to memorize the whole thing start to finish, which I did not think was a very useful practice. And it did not prepare me for the wealth of experiences that I will encounter in community mental health. So what are some boundary or ethical pieces that early career clinician may benefit from?
I think managing the question that's always bound to her, not with every client, but especially early on. How old are you?
Me?
No, that question. When you're working with, especially early on, because you are young. You know, you just got done. For most folks, you are young, and I mean, I've had some supervisees too that like look even younger than what they are. Yeah, you know, and you got all wide ages coming in, and especially like with family-based, the questions that we would always get is, how old are you, and do you have any kids?
Yes.
Mm-hmm. You know, and so how to navigate those questions, because you're gonna get them, or other similar related questions of like, oh, well, what religion are you, or you know, like all of those types of personal things, or where do you live? You know, where sometimes it's just people genuinely being curious and friendly and just trying to get to know you a little bit because they're telling you a lot about themselves. Mm-hmm. Sometimes there's weird boundary things going on that you may or may not realize, especially depending on when in the process of meeting that person these questions are coming up. So some of those things too, like being able to be therapeutic about it, but also finding for yourself, like, what are you okay disclosing or not disclosing? Is it certain clients that you feel like okay disclosing or not disclosing? Or, you know, are you okay with giving a range? You know, like, I'm in my mid-30s, you know, something like that. You know, or I don't have kids, but, I mean, I do now, but at the time I didn't, you know, I don't have kids, but I've been a kid in a family, you know, and I know interactions and I know what it's like to experience that, you know, and so finding what you can lean on.
When I had the benefit of starting my career in forensics. So like, no, I haven't committed a sexual offense. Like, I've never sexually assaulted somebody. I'm not a content expert in this area in terms of lived experience. And I don't think I have to be to support you in this space. But I think there's all like that type of thing. I think I had that benefit early on in working in a very niche area, that it's not expected that I have applied or lived experience with those things. Now, I did have quite a few folks that sometimes struggle with the fact that I wasn't male. Like a female coming in young with that lack of experience, which is, you know, just part of our work. That's our workforce. There was often those different dynamics. What's your advice to supervisees when they say, this client keeps asking me questions, what should I do?
Usually it's the starting out of take that back up, you know, and like validate their curiosity. Like, I hear you, like, I'll answer your question, but also, what's bringing that to the table? Like, why are you curious about that? And then sometimes actually that can help you to gauge how open or general you want to be with your response. So like still answering in some way, shape, or form, but kind of gauging how much you feel comfortable disclosing with this particular client, given what they're presenting.
Yeah.
And also why they're curious. And then you can address some of those, if it is like, well, I'm wondering about your experience. You just seem pretty young and I, want to make sure you can help me. Okay. Well, absolutely, I can help you. And I consult on my cases just to make sure that I'm helping you to the best of my ability, being able to address all those things with them.
Yeah. And I think also that I love that the curiosity with it, the validation. I think there's also that piece of recognition that it's not there's no there's no clinician that's going to have every single experience that perfectly overlaps or relates. And I think it's always valuable to stick in that less is more space until you deepen the relationship to a point that it makes more sense. I was raised by two psychologists that were trained in the 70s. So I grew up with my parents' clients coming in and out of our home. I grew up with my dad would go pick up all of the clients at the alternative to state prison treatment facility, put them all in a van and bring them to our house to watch fights, or to take them hiking. So all these different, when you zoom out and you think about, this man went and picked up, 15, 22 to 40-year-old men who are incarcerated for substance abuse issues, and they bring them home to hang out with their teenage daughter. That's an interesting dynamic in terms of boundaries, but that's also the boundaries that I was raised with. And so it took some time for me to really recognize that I needed to identify the boundaries that were going to fit for me as a provider and be the most effective for me as a provider moving forward. And some of that therapeutic milieu stuff that was real popular in the 70s and 80s isn't conducive to sustainable practice in the managed care arena. And it's okay to have your boundary set.
And that boundaries are an ongoing learning process.
Yeah.
What boundaries looked like for me 2 years ago, that's kind of scary as far as my scheduling and how much of myself I was willing to give to the altar of community mental health, and then now 2 years later I'm no, I'm not doing that. No, period. That's just, it's a full sentence and we're done. I'm not available.
And when you did that, when you started setting those boundaries with your clients in terms of your accessibility and availability, what did you notice?
Well, going into it, that I was terrified because I have this thought that, had the thought that if I'm going to be effective and helpful to you, I need to be available. That's not reality.
No?
I can't pour from empty cups, right? I can't. When I did it, I found that it wasn't as scary as I made it out to be. And that maybe when I'm setting the boundary, this is possibly the first time that someone safe has sent a boundary with a client. And what does that mean for the rest of their lives, right? To be able to see, you know what, Andrea, said she couldn't see me this day. And that really sucked, but she saw me the next week. And I'm
Yeah.
She didn't take my phone call. Oh, well, we talked about it next time, Yeah. It's teaching them that, there's limits in all relationships, and they haven't had that. A lot of the folks I work with, have not had that.
No, obviously psychotherapy is the microcosm, right? Yeah. So it's showing them that all relationships have boundaries. These are the boundaries for this relationship, but other relationships likely need some boundaries as well. I think it also, our clients are pretty sturdy. They're pretty sturdy. And I think that we unintentionally invalidate and infantilize them by being too present, by being the Superman, I'm going to strap on my cape and show up for you in this moment because that's what you need. And if I didn't show up, they were going to be okay too. And there are instances in which that's not true. Right. But by and large, our clients are going to be okay if we don't show up in that moment. And how do we create their ability to tolerate that space so they can be their most effective self?
We're not really being effective if we're showing up for them as much as
Always,
I
yeah.
thought, right? Because if our goal is to work ourselves out of a job, which it is, then we are setting them up to be independent and not need the weekly session, maybe not even need the monthly session. Like, fly, little birdie, you're good. So,
And they can come back.
they can always come back.
Yeah, if a different
Yeah.
life phase, if a different season. I mean, that's a big part of my termination session with every single client. And it took me some time to develop my rhythm for some of those like types of sessions, right? Like the termination session is arguably one of the most important sessions you'll have with a client. Do you know how many termination sessions I fucked up before I figured out like this is how I end? The intake till you find your system, your rhythm, your patterns, your clinical identity, who you are as a therapist within that space. It takes some time though. Eden, it felt like you were starting to say something.
Nope.
Okay.
There's also too, I'm thinking of with setting the boundaries as far as like maybe scheduling outside your scheduled hours and things like
Don't
that
do it.
because they need it and I'm here to help them. And then how awful is that when they don't show up for that session that now you came in 2 hours early for just so they could have that session and they did not show and they did not call to tell you that they
That's a rite
changed
of
their
passage.
mind.
We all have to do that once. We all have, right? Has everyone done that?
Many times.
Yeah.
Not early, but late. It's so funny. My godfather, he's a therapist as well. One of the things he'll commonly say is, if you give a client like that primo, like 8 p.m. Tuesday session time that's like just great and very comfortable and easy for them to come to, but then you're staying super late at night to see this person, they're never going to let it go. They're going to keep that. And you're going to keep coming late because you wanted to satisfy, you wanted to make them comfortable by giving them this spot. And I think there's some validity to that. I don't think it's wrong to stay late and see clients in the evening because people have jobs. But, yeah, I think you set up yourself for failure sometimes by just being so flexible for people.
Yeah.
Right?
I think it's a bummer because this job is super flexible and this job is super flexible. And there's a lot of benefits to that, right? Like there are times where I can, if I know it far enough in advance, block my schedule, go to my kid's school for the day, or like I can do some really special things. And in those weeks, like if I take off a Thursday, I might work a little bit later Monday and Tuesday that week, or I might, flex my hours and go outside of my schedule because it serves me. But I will never, like if I have a client that says, oh, I need 7 p.m. on Mondays, that's my only time. It's like, then I'm going to have to transfer you to somebody who can see you at 7 p.m. on Mondays because that's not when I work.
I think there's a piece to like developing a sense of comfort or comfortability and just saying these are, I need to set these boundaries, right? I work these times or I need to change this time slot even. I know we've been meeting maybe Tuesdays at 8 p.m., but that's no longer something I can maintain. And so we need to figure something else out. And oftentimes, again, I think being genuine with clients, they appreciate that. And they're willing to work with you. Most of the time, I very rarely have had instances where someone says I need Monday at 7 o'clock and that is all I'll do. It does happen sometimes.
Absolutely. Yeah, it's the whole give an inch, they take the mile. Not even just in this profession, in life. But I mean, so with Family Base, I have an awesome clinical director. So she always gets like availability before we even open. She's great. So we'll look at a case and it's like, okay, we know we have like 3 to 6 open a couple days a week. It says mom's available all day. We show up and mom's like, I can only do 6 p.m. Fridays. Coral in 2020 would have been like, that's fine. It's cool. I'll burn out. I'll cry myself to sleep. Like, it's fine. But nowadays, I challenge that. Like, well, I noticed you're available. Like, you don't have a job, which, like, it's great. You're stay-at-home mom. Like, you have all this time. It's awesome. Like, you're spending time with the kids. And then I also challenge, are these services right for you? Because I used to be so hesitant. We're like, I know I got to get my hours done with these people. And now it's the first 30 days going, okay, is this the right service for you? Because if you truly only have that time frame, we are not going to be able to give you the family systems work that we are hired to do so. So I definitely think that's a boundary, especially with a partner too. My partner does not like working on Fridays. I like to have some time on Mondays, and we stick with that unless if we know something else is happening during the week. So even if families are like, oh, I only have this and this, give them 2 choices. If it doesn't work out, case note it, document it, let your supervisors know. So I've definitely grown in that aspect because I was a certified people pleaser, probably still, but it was bad where I was allowing people, like other people, to control my life. So I think that was a boundary I needed to set for myself.
I think I've seen that a lot with people, newer therapists, and myself too, who, when somebody comes, they're mandated for treatment. The recommendation is that they attend group treatment. There are only so many groups that exist within, that person can join into. And so oftentimes you'll hear the person then say, oh, I work 6 to 6 Monday through Friday, and the group is at 4 o'clock on Wednesday. You've got to figure it out, or you can seek treatment somewhere else. And I think that's an unfortunate reality because, again, we want to help. It's not that we don't want to help you. It's just that this is when the group meets, and that's all there is. So, and I think that's very difficult for a lot of people.
I think it's difficult for a lot of people, but I think about like my own life. Like I've never called the vet or my dentist and been like, I want to come Tuesdays at 11 o'clock and I expect you to see me. Like there's no other profession where we're expected to just have this open availability where people maybe like, I think maybe hair, I don't know, like where you're expected to have more that one-on-one, more personal connection. But usually we had to get our freezer fixed a couple weeks ago. We had a 5-hour window. That's the day he was coming. Doesn't work. We'll see you in a couple weeks. That I don't know. There's just so many other professions where it's totally okay to say these are the available hours and times. But in this field, it taps into something within us.
And I think some people, they recognize that we want to help. And this may just be because I'm working with, again, clients who are mandated. They don't necessarily want to be there. They're resistant in some way or even angry about the fact they have to come. But they may know that.
Yeah.
And so they may use that, right? And they may push and see your willingness or desire to bend the rules or bend your own schedule to meet their needs. And they may use it. And I think that's also difficult for people to address and to maintain strict boundaries surrounding. And I think that one of the things I've heard before is that people feel as though they're being mean.
Yeah.
They're being mean by staying, firm with their boundaries.
Something, Coral, you had mentioned, and I want to go back and sort of highlight and hover over it for a moment. What is this the right service? Is this the right service? Is this the right level of care? Am I the right provider? Is this a fit? And when it's not, having that conversation. I know when I started in the field, that was such a hard, because I just wanted to be flexible. I wanted to meet you where you're at. I want to help you. Oh, you can't come to IOP, but you need IOP? Well, I suppose I could recommend a 1A level of care, plus individual sessions, plus this, plus that, plus this, plus that, and try to cobble something together that works for that client. And I think so often, especially in like the workforce shortage and some of the gaps within our system of care, we don't have the ideal treatment setting available for this person, or we don't have the ideal amount of resources that specifically we would be looking for this client. So we have to do that out of necessity rather often. But I think there's also, especially early, client preferences, which are important, are still not everything. And so there are times where, I think one of the big ones is group versus individual treatment. Our treatment philosophy is that if you are a mandated client, there is value in the group process. There is value in the group collective. The data, by and large, supports that over and over and over again, that if you are in a group, you will get more out of your psychotherapeutic time when you're addressing drug and alcohol and other forensic or those sort of events. And yet, I would say that is one of my hardest the conversations that I have with a lot of our early career clinicians when I look at their caseload. And I'm like, you have 30 clients that should be in group on your caseload. What are we doing here? And honestly, usually the conversation isn't with the client that did it. Or a clinician that did it, the conversation is often with that clinician is now left, often not in the best way. And we are now cleaning up this caseload. And now you three were like, all right, I can take a couple of clients. And I'm like, great, here are some clients. And now you have to go in and reorient this client to new, maybe slightly healthier boundaries. And no one enjoys that job, like having to go in and be the therapist. And so I think sometimes, to speak to that nice point, we think we're being nice by over-functioning or doing things that might be beyond the standards that we should be holding. We just had that recently where we had a clinician. I think you inherited some of this person's clients within the last year, where this person was calling their clients just to check in, just calling to check on them because they were worried about them and just having those little human touch points, which in theory sounds really nice. But in practice, I think develops some dependency.
Yeah.
And I think in practice creates a standard of, because then when that caseload was absorbed by other providers and they weren't doing those calls, then what? Makes it weird. The other piece so talking about things like no-shows, payment, your balance, you're not, we talk about polygraphs, right? Our forensic program utilizes polygraphs. They get a big bill once a year for that. They love it.
So kind of like in the same vein as like, I don't know, just some of these these topics about like, have you ever done drugs, right? Or, you know, how you've never committed a crime, you've never been to jail, right? When clients ask questions about those things or point them out because, you know, maybe they're afraid of whether or not you'll be able to help them, right? Those kind of things. In a similar vein, right, one of the things that I feel like I've had to deal with, and I still deal with it today, like a significant amount, and early career clinicians have to deal with, is this is a money scheme kind of conversation topic. And the polygraph thing made me think of it because when you have to tell a client, listen, you have to pay for a polygraph, a therapeutic polygraph is a part of your treatment, they don't love it.
And it's $400.
Yeah, they don't love that.
Nope.
And they don't see often early on, maybe they do see, but they don't want to see the validity associated with utilizing it in their treatment. And so they push back and they throw out these systemic theories of conspiracy. And I think for early, you know, career clinicians, it's really hard to figure out how do I talk to this person about this? How do I address that? Especially in a group setting where you might have 6 to 10 people that all kind of jump on this train and they're all very, you know, maybe upset about it. Yeah, it can be difficult. I think that can be difficult.
Yeah. I think that piece, but also that's what makes therapy different than any other type of relationship. Like, there are very few other relationships in which I pay you to hang out with me for an hour. Like, that's just not, there's not many, I mean, babysitting maybe, but there's not too many jobs quite like that where there's an exchange of money for a service and the service is just being with you. And I mean, we know it's more than that, but that's what it is in that zone. Even like pay your $25 copay. And that's a hard conversation because I know that my client's one of his like distress factors is money. And now I need to come in and say, listen, you've not paid your last 3 copays. You're getting a balance. So we're starting this new private practice here at PCS called Live Up Counseling. We require all of our clients in Live Up Counseling to maintain a credit card on file. When we started a year ago, we didn't require that. But what we noticed is these clinicians are not early career clinicians. Many of them have been in the field for quite some time, but they had admins that would check them in at the window and say, hey, you owe me money, pay. Like, other people were having those conversations for them. Yeah. Back when PCS started, we had the therapists have the conversations. The therapist collected cash. When I started in forensic, I'd have you sign in on the sign-in sheet, and then I would physically take cash from your hands and put it in an envelope. And I would have to courier that envelope to HQ. Those conversations we don't have as much anymore in the field, but they're uncomfortable and they're difficult.
I think that's one of the like ethical pieces. A conversation I've had a lot of times is just the idea that certain people will say, certain supervisees I've had have said, there's this weird feeling that they have associated with, I want to help you, give me money, right? And we're not collecting the money ourselves, but just the idea that there is a fee associated with the help we're providing being just a strange dynamic to navigate within these relationships. And I think that's true, but kind of similar to what you said earlier. You pay a veterinarian, you pay a doctor.
Yeah.
Your time is valuable and you deserve to be paid for your services.
We're not volunteers.
And like you said, the dynamic, the relationship is different. We're not also friends.
And sometimes having the weird conversation about like, hey, I noticed you haven't paid your copay and you're telling me you can't pay. But I've also noticed that you've shown up with brand new sneakers and a new fitted. And is that the iPhone 27? Because I'm still over here on the iPhone 6. And like sometimes it's also about like, where do you prioritize your money? And many of our clients do have financial concerns. Like that's a valid, like that, especially in community mental health. I remember when my husband was doing a lot of direct care, he used to say, like, all these people need is just money. If we gave them money, half of their problems would go away. And I disagree with that wholeheartedly. But I think that many of our clients have that like that is a staple. That's one of the reasons you get medical assistance is financial needs. And I've noticed that you have Yeezys on and this really large, you owe me some money, and I don't have Yeezys on. I bought these particular shoes for $11. So could you pay your copay? But those conversations are tough. They're uncomfortable. So one of the other things that is on my list to address here today is documentation and record keeping of the early career clinician. And I will be the first to say when I started in this field, I thought it was all bullshit. None of it mattered and it wasn't important and it was a big old waste of time. And why do I have to do this? And I will still contend that quite a few things we are required to do is a big old waste of time. And if our managed care companies really wanted to improve the quality of care, they would reduce the burdensome or like family-based treatment plans should not be due in the first 30 days. The assessments should not be due in the first 30 days. You need more time to do those things. So I think there's a lot of pieces there where I don't agree with the practice. And I was talking to somebody the other day. I do believe that case notes save lives. I do believe that it is a necessary and essential evil. And I know as an early career clinician, bottom of my list, and I know I'm not the only one.
I think I usually have the conversation with supervisees about it of like finding what works for you to streamline your process.
Yeah.
Like I know what works for me and I can tell you what works for me, but that doesn't mean it's going to work for you. But you can try it and then maybe modify it because you got to find something that works because it's so important.
I've recently been doing all of my documentation collaboratively. So we rolled out collaborative documentation in family-based a couple months ago. It's coming to outpatient soon. But essentially this idea of at the end of my session, that's how I summarize. I share my screen with my client. We go through their the different sections and they see exactly what I write. And I have one client in particular who has a pretty significant legal history. And a lot of just sort of the inherent trust-based challenges associated with somebody with significant trauma and systemic oppression and all those different things. And when I started using collaborative documentation with this client, it was a game changer because I think for so long he was worried about what I write after the fact. And there were certain things that we just didn't, like he would flash that it's there, but there's parts of his, he's like, well, there's parts of my history I'm not proud of. I did some violent things once upon, but like there's always that like, what are you going to write about it? What are you going to say about it? How are you going to characterize it? And him being able to see how I keep my records completely shifted the feel within the room, because now he knows how I will document that thing you said. And it creates that safety for him to process things that he genuinely needs to process, because he has a lot of moral injury based on those behaviors. And he was always really reluctant to discuss those behaviors because of the fear of what I would do with it.
Yeah, I'm sometimes worried about the early career clinician, the supervisee that I have, and their use of collaborative documentation to potentially just, I don't know, save time on doing notes later. I'm sometimes worried about that, but I think there are often, and if you know how to manage and implement it correctly, I think it's very beneficial for the client to see what you're thinking, because I've had many instances in which the clinician that I'm working with, or even in clients I've worked with myself, they don't know what I think. And maybe they feel as though there's a plan and they don't understand it super well. So I think one of the things that's been beneficial for me over the past couple of years is really working to break down certain paperwork that I do. Like treatment plans is probably the most valuable thing to do with the client. But I think there are periods of time where, like, talking to them about what we're doing or about what I'm thinking, my assessment, because it's not a magic trick. That's commonly something I'll say. I'm not trying to keep things from you or behind the scenes do something that you don't see, and then at the end I have a rabbit, right? So I want them to be involved in this process. So I think, again, if done correctly, it can be a valuable tool.
It's a part of treatment.
Yeah.
Treatment planning is treatment.
Yeah.
And especially for the mandated client, like giving them some sense of agency in what this process will look like. So
I think it's also a great opportunity. I mean, the collaborative documentation, well, it was funny. I was kind of skeptical about it at first because I saw it a little bit more in that, like, oh, you just save time. And I don't think there's anything wrong with saving time.
Sure.
I think there's a lot of value in, I hate that many of our therapists on Saturday night go home and write notes on a Saturday. Like, no, get your shit done on Friday and be done, be off. Like, disconnect, recharge, all those things I think are important. So I am not throwing shade at all. Like, I think saving time is valuable. And I think that if you don't do it collaboratively, it's not going to be therapeutically effective. But I think collaborative documentation, it's trauma-informed, it's egalitarian, it allows that. It also is a great way to clarify any, like, missed signals or misunderstood. Like, I think therapy is ripe for misunderstanding. And so there are times where in those collaborative moments is where I'm like, oh, no. Oh my goodness, I didn't say it. That's not what I meant to say. Oh, I'm so sorry. I came across that. No, what I was intending to say is you're incredibly resilient. Look at all you've overcome. Like, you just told me my life sucks. It was like, oh, no, that's not what I'm trying to say. So I think it's also a really nice way to make sure you're all on the same page and have that buy-in before you leave, like that there's that plan for in-between session, and kind of have more continuity across sessions as well. So I'm a fan of collaborative documentation now, but.
Yeah, and that's what I was getting at with the magic trick thing, is that the clients are often interpreting what we're doing, and that understanding what their interpretation is super important. So yeah, I agree.
But it has to be, like, part of the, like, when I do collaborative documentation with my clients, it's like 5 to 7 minutes. Like, I carve out a chunk of the therapeutic session for it. Now, I do 60-minute sessions, so I have a little bit more. I know a lot of people do, like, the 38 to 52. I do the 53 plus on almost all my sessions. So I carve out that time. Like, my pediatrician, when he's done, I think it's probably your pediatrician as well. I think we all go, Dr. Mizoyan, do we all go to the same one? Oh, no, okay. I thought we had talked about how we both saw him. But my pediatrician, at the end of all our peds appointments, he sits there while we're sitting in the room and talks into a microphone and goes like, client did this, we had that, he's this tall, he's this, blah, 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 blah. There's nothing collaborative about it, but he does my documentation before we even leave. I don't think therapy should be that way. I think there has to be more back and forth. Listing interventions, that sort of thing.
Yeah.
I feel like the collaborative documentation on my end, so I'll be honest, maybe 1 or 2 notes a week I do it, just because of time and place, there's certain families works with, doesn't work with. I think it's a great way for reflection, because sometimes, like, I'm sure you guys experience this, you kind of get a sense with certain sessions, like, did they even get anything out of this? Or like, were they paying attention, especially the ones that are like their phone's kind of over here and like, you're spotting things. So it's just kind of a good way to make sure they're getting something out of this. And if they're not, like, what's the disconnect? That way we can think of steps for like the next session. So I find it very useful. I personally don't use it for like every single session. It's a lot of like individual sessions. It's really, really helpful.
I also, when it comes to collaborative documentation and documentation in general, not waiting to the last minute, those sorts of things, I think the longer you wait to do your documentation, the longer it takes to do your documentation, and the less accurate that documentation is. I think the further you get from the thing, the more, I heard it once, a progress note is an impressionistic painting of the session. And the further you get from the time in which the therapy was conducted, the more impressionistic it becomes. But I think there's that value in having accuracy. There's that value in having that agreed upon narrative that happened within the therapeutic room. I think it also can be really reinforcing as a therapist, because like that session where you walk, like, did they even get anything out of this? And they're like, oh my God, you said this thing and it was really important to me. It's like, oh, it's not all hopeless bullshit. Yeah. It's so nice. I have value. So I think there's a lot of value if the client is appropriate for it, if the client is willing to opt in. I think group, it would be really hard to do collaborative documentation, at least all the pieces in a group setting effectively. You might be able to do like the one thing, but the rest of it, I don't know how you would do that in a group setting.
No, but I think oftentimes, again, if people miss and you see them individually because they've missed a session, things of that nature give you opportunities to kind of talk about where they are, how they're doing, et cetera.
Those check-ins.
Yeah.
I also knew, like, when I was, it would have been 8 years ago now, I had a ethics investigation. I had the licensing board investigating my license because someone made a complaint against it. And I remember that being probably one of the scariest times in my life, and in my career. I just found out I was expecting my oldest son. So I just discovered that my life was about to change like pretty significantly. And then also the thing that feeds my family and pays my mortgage and all those things is now at risk because someone said I did these things. And like last but not least, these things I just didn't fucking do. Like, it just was a lot. Like, it was like a bold-faced lie. It was like this like, it was preposterous. And I remember in that moment, like, just being terrified. And I sat with Michelle Williams, and I talked to Roy. Roy's like, this will happen 1,000 times. Don't worry about it. I don't know. So there's all these different things. But I remember sitting down and going through the stack of paperwork I had to pass over to the licensing board, just this stack of like 300 pages of stuff. And I remember I'd never experienced a greater sense of gratitude towards my documentation. Usually I resented it. And I'd be there like rage type, like motherfucking, like rage type. Like I always hated my documentation until that day happened. And then I'm licensed today for 2 reasons. And I've said it like, I didn't do it. I didn't do what they said I did. And so that's helpful. And I had 300 pages of documentation to show I didn't do what they said I did. And that's when it shifted for me in terms of appreciating my documentation versus resenting it.
That's definitely a fear of mine in this job is, and I'm sure just like any other profession where you're working with people, is if I say the wrong thing or I've had a couple pervy dads that I've worked with, not going to lie. It's just like, they could say anything. So it's just always like, is someone going to try to ruin my life? So that's always definitely a fear, like in the back of my head with this job, documentation wise, giving therapy, safety.
But I see the documentation is like, that is your protective factor. And I think to the early career clinician, there will be clients. I mean, we're working with people who are sick. We're working with people who have diagnosable, identified mental illness, and we are here to help them. And their interpersonal effectiveness is often impacted by that mental illness. And the therapeutic relationship is still a relationship. So it would stand to reason that interpersonal stuff that's tied to their clinical diagnosis is going to play out in the therapeutic relationship, and sometimes it's going to play out in a nefarious way. They're going to call a supervisor. I get calls from clients. Well, they told me this, and they didn't. Blah, 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 blah. I mean, I've gotten from your clients, Eden. It's true.
I can think of several.
Yeah, you can think of a few names. But I always do my due diligence, like about, hey, Eden, I heard from so and so, and I mean, I as a supervisor never just take it as fact. I don't take it as gospel. I always go back to the supervisee and want to get the other side of the story. But yeah, it could happen.
For sure.
And I think to that point, like for the newer clinician, especially to PCS, I think there needs to be a process of like learning to rest in the fact that the agency has your back.
Yes.
And that if a client is saying that you did X, Y, Z, the agency's go-to isn't, oh, well, you did that. Mm-hmm. It's curious questions, right?
Almost always.
Yeah. So understanding that and not overthinking a client complaint. My first year, negative Google review.
You got a negative Google review. Oh.
And whew.
That was a tough one. That's a tough one.
I like broke down because of it. I started questioning, like, why am I here? And then some time went by. I processed it in supervision in my own personal therapy because all therapists should be in therapy.
Yes.
And then one day the Google review was just gone because that client had worked through whatever they needed to work through. And from that, it's like, you're not going to make everyone happy. Your job is not to give them what they want. Sometimes what they want isn't what they need.
Yes.
And those are just like some very uncomfortable like lessons and growing pains in your first few years. So.
And I think that's been every instance in which I can recall anyway, or that I thought of whenever you brought that up. It's been clients who are angry or frustrated with just the way in which mandated treatment works and therapeutic tools or interventions that are, part of their treatment. And again, that's usually often something you work with them through, and sometimes it can be a trust-building experience. And I think it's often good for the therapist to, because they're real emotions and real reactions that people have about the experience they're going through. And so I think there's just this is what this person has going on, right? And I think you can often connect them through it. So despite it being this thing that, has given me anxiety, and I'm sure will give other people anxiety in the future, it's a growth thing for you, the client, and potentially your therapeutic relationship with them.
Oh, and I think also to say, I don't know if this is too heavy-handed, but it will happen.
Yeah.
It will happen. You will have a client. If you're doing therapy for longer than a week, you will have a client that's going to call the office and be like, Sarah called me a mean name or whatever, like you will have a client that's going to complain about you. You're going to have a client that in some ways will threaten you. I mean, that's a common early career. Well, if you don't do X, I'm going to report you to the insurance company.
Eden will not work at 9 p.m. at night to make sure that I can attend an all-day, festival every single week. It's just not, it's going to happen.
I'm going to report you, and my response to that is always, that is your right. And we give them at intake, right? We give them that piece of paper. If you have complaints, these are all the ways you can complain. That is your right. And what you need to know is if you choose to go that direction, I can no longer work with you. But you are allowed to do it. You can complain to me on all those different places. You can go that direction, but I cannot have an authentic therapeutic relationship with you and need to protect myself from you. And if you put me in that position where I need to protect myself from you while also serving you, I can't do that. You're putting me in a dual role that's not feasible for me to realistically navigate safely. And so you can do that. And if you feel like you should, I think you should. But then you need to know I will need to discharge you and refer you elsewhere.
Some of the mandated clients, and I brought the idea up that some people will try and, they'll use your flexibility and your willingness to, want to help them and to kind of get you to do things that you might not otherwise want to do, like work at 9 p.m. on a Tuesday. And I lost my train of thought there, but I'll get it back in 2 seconds.
Sure.
And then I'll come back to it, but someone else can.
Colin will clip this out.
Yeah.
Thanks, Colin.
He doesn't have to.
Just leave it in.
You're going to be talking to a client and you're going to lose your train of thought. That's also realistic.
That's also very realistic. Yeah.
I'm like, the train's just making a circle and we're back. Okay.
Yeah. I think also, and this just brings up like a whole nother, when running group or running having a therapeutic session, I think oftentimes too, again, with the performance thing, when people lose their train of thought, when people forget what they're supposed to be doing, that can be an anxiety inducing thing. What do I do now? Where do I go now? There's a lull in the conversation. What am I supposed to do? And I think also silence is a big thing that people struggle to utilize. I think patience and being willing to sit in that is okay too. And often I've also learned that when you sit in it, the client they're reflecting, they're thinking internally about what you've been talking about. And sometimes they'll start to talk about things that are very valuable for you to hear. And so by trying to force the conversation to continue, sometimes you lose out on valuable feedback from them that you could have gained. So
I think it's sometimes it's that addition versus subtraction principle. Like I think when we meet a person who is suffering, we think, what can I do, or what can I give them, or what can I, what series of words or sentences or phrases can I pull together that can make this suffering less for them? And in those worst days, in those deepest points of suffering, there is fuck all anyone can say. There is nothing that even the best therapist in the whole world to show Carl Jung himself. I don't know, whoever you think, Martin Seligman. I don't know. There's lots of great therapists out there, any of them, that there is nothing they could say in that moment. And I think that those are the moments where silence is most important. Or those are the moments when you feel that like bead show up in your belly that says, say something, you've been quiet too long. It's getting awkward. They need something from you. They're looking, and like, you just like, bleh, like compulsively say something in that moment. I think that's where silence really could have been the secret sauce.
all I had been attempting to, because the train came back around.
Hey, train.
Yeah, look at that. All I had been attempting to identify was that some of the clients who may want to manipulate or, utilize your kindness, your willingness to help them, to make you work in different hours. Sometimes the threats that you may get, I'm going to report to the licensing board, I'm going to call your supervisor, are just continued attempts to make you do things that you might otherwise not, right? Because I don't want you to tell on me. Don't do that, right? That could be scary.
And this person I'm really trying to impress is going to know the truth about me, which is that I have good boundaries and I won't stay until 10 p.m. on a...
And that can be really frightening to people,
Yeah.
especially, again, early career clinicians who just started. They don't want someone running to their supervisor to tell them how bad they are.
No,
Yeah.
because they're afraid of getting fired as it is.
Yeah. Or again, that they'll be unmasked to be this person who just started working, which you, again, if there is legitimacy to it, they just started working. So.
But that brings up a good point too. You will get fired, air quotes,
For sure.
by clients. I mean, I got fired by family-based clients. I got fired by outpatient clients. It's happened.
Yeah.
And it's going to happen. It's okay.
Yeah, your inability to help every person that exists out there, that's all right.
You're not going to be a fit for everyone.
Right.
And I think that's okay. You're not everyone's cup of tea.
Yeah.
And that the fit within the therapeutic relationship is one of the most essential and effective components of what makes therapy work. And yet, so often we personalize that. We take that personally. I've used the example, and all of you had to go through it. But my trauma-informed care training, I used the example of a client that I had worked with for about 2 years. And when I met him, he was acutely suicidal. He was one of those that every time he left my office, I was like, oh shit, is he coming back? Is he gonna, he's one that I Googled. I'll admit it. He no-showed me once, and I like Googled the obits and the police blotter, and just to make sure, because I always really worried about this guy dying by suicide. And so we worked together for about 2 years, and he fucking changed his whole life. He went from like this really small existence to like connected. He got a girlfriend. He got all these social, he got really active in his church. He started a small business, like just amazing. The progression of this guy throughout the course of his time in therapy. And then he came into my office one day and he said, hey, I'd like a new therapist. And like the record screeched to a halt for me. I'm like, the fuck you want a new therapist? Like, I have helped you. Look at the good work that we've done. Look at you were gonna die. I was certain of it. And today you're doing great. And we like each other. We get along. What's going on? And luckily I didn't say any of that. And instead I just said, oh, tell me more about that. Or can you help me understand, why you might be thinking that? And he said, well, if my whole life I've not been safe to work on this, but I have this childhood sexual trauma that I need to work on. And you remind me of my daughter, and it would be weird to talk to you about it. And so I think the work that we've done together has been tremendously effective, but I would quite frankly prefer to work with a male clinician for this content area and for this next season. And it's like, oh man, there it is. So, I mean, sometimes you're not even the wrong therapist for them forevermore. You're just not the right fit for them in that room, in that space, on that day. And maybe 5 years from now, you will be the right fit. But that's okay. It's not personal, and not personalizing it near as much, because you're going to get fired. Sometimes you're going to get fired in a really mean way, and they're going to make you cry. Or at least they made me cry when they fired me. And it's a lot less about you.
Yeah.
That's progress too, though. Like when they're able to have that conversation about it not being a good fit, especially if they're coming in and like they don't advocate for themselves and they're like, you know what, this isn't working. It's like, yeah. Say more.
It's not.
Yeah, I think also, again, as the helping professional, if your desire is truly that they get better, that they get the help they need, then, right, this is a good thing.
Right.
That's what matters.
Yeah.
Hopefully they get that. Yeah.
And recognizing like the opposite end of that spectrum as well is that you can never be the only one. Because I've navigated that with a lot of early career. Well, I'm the only person this child has ever trusted. I'm the only one. It can only be me. And to me, like when I hear that sentence, my shoulder blades tighten up. I'm like, all right, we're gonna do some boundary work, because we are enmeshed. Like that shows to me a little bit of a level of enmeshment that we need to address to create safety for both the provider and the client moving forward. And we see that with like levels of care. I've talked to outpatient therapists who are like, I'm not referring this child to family-based because I have the relationship with them and they won't. And there's no therapeutic relationship that's the right fill-in for the wrong level of care. But so often we both overestimate our own importance, I think, at times in that space. And that sounds like narcissistic. I don't mean it in that way, but like we fail to recognize that others can also develop a trusting and safe relationship with this person. And that may be even ideal. That might be better. So one of the other areas that I thought would be useful for us to discuss briefly and this is what I do during my startup training here. So at Pennsylvania Counseling Services, when you start as an outpatient therapist for your first 12 weeks, you do like a 4 to 5 hour didactic training on a whole host of different topics. I do the one on trauma-informed care. And a big part, or at least the last hour of my trauma-informed care training, is looking at like stress, burnout, vicarious resiliency, moral injury, vicarious trauma, transference, countertransference, and care. And so I guess what advice would you all have for that early career clinician? I think you already said it. Go to therapy. Go to therapy. Get nothing else out of this. Go to your own therapy. But what advice do we have for the early career clinician that showed up to the very first day of their work and they realized, oh shit, this is touching something inside me that doesn't feel good or comfortable? What do we do in those spaces to create safety for ourselves in doing this work?
Lean on your team.
Yeah.
Like, I think that's the beautiful thing about our agency is that we have clinics. There's a culture in each clinic that varies. I mean, Carlisle's different than Chambersburg, all of that. Lean on your people in your clinic. Not to the point where you become like a culty, like family, right? But lean on your supports there. Be vulnerable. I know I keep saying that, but like open yourself up. You don't have to drown in your paperwork alone. You don't have to schedule that client that makes you uncomfortable at 7 p.m. and just keep that to yourself. Like, lean on your supports. When you're stressed, say that. Just communicate.
We had a similar conversation in one of our treatment teams probably several years ago now. And so I'm gonna quote the great Jeff College. He's one of the awesome therapists at our office. But he had suggested looking for the light, because if you know about how Renaissance is structured, there's 2 hallways where all the therapist offices are. And when somebody's door is open, you can see the light on the floor of the hallway. And so if you're having one of those moments, you had a tough session, you don't even need anything. Like, you know what you're doing, like you got it, but you just need that, like, oh my gosh, this like just happened. I just need to offload this on somebody. Look for the light, like look for whose door's open and go chat. And it's one of the cool things I run, like pretty much anybody's good for that. Like, I know I could stop at any door and just be like, hey, this tough thing just happened. Can I share it with you? I don't need any like support or advice or anything. I just need to share it with somebody. And I think everybody would be like, yeah, what happened? And be totally open for that.
Yeah, no, I do. My job is so mobile, but that's like pick up the phone and call somebody. You got a minute? I don't need anything. I just need to scream into the void for like 5 minutes because this thing just happened. Or even if it's like I know what I'm doing, but I'd like a different perspective or consultation. Yeah. Any other pieces sort of tied to that? Your personal narrative being stirred up in those early days.
Sorry, I breathed in like I was going to say something.
I was waiting for it.
Yeah, I was thinking about something. I don't know how relevant it is. Well, I'll say it anyway. One of the things that sometimes I'll talk about with supervisees is just when somebody says something that's either super shocking or just kind of hard to hear or does stir up something that you internally have, right? Oftentimes, if that's difficult to process in the moment, we'll talk about how you should respond, right? And what you can do afterwards, right, within that relationship with the client. And I think that's often very difficult for people. So in the moment, usually one of the things we'll talk about is to just sit with it. Again, that's one of those moments where silence may be a very beneficial thing, both for you and for them. Give you both a moment to think about it. Because again, if they said something kind of out there, kind of just tough, you both may need some time to just kind of sit with it. And I think that's like one of the great things about the therapeutic relationship is that you're both human beings and you can have genuine responses to things. And I think you can also talk about that to some degree with the client, right? They shouldn't expect you to be a robot and you shouldn't expect yourself to be one either. So I think that's one of the big things I thought of. And I expected that of myself early on. I remember thinking to myself and talking with Susan about getting angry, right? Or because of just some of the ways in which clients would talk or behave within group sessions or things of that nature. And it's not necessarily related to something that had stirred up within me about myself or my own journey, but just having those emotions, even if it is related to that, I felt uncomfortable with it, right? I'm here to help you. I shouldn't be angry with you because that's not going to assist me in helping you. And so, but again, I think there's something valuable about that. And if it does do something, stir something up with you, there's often so many different check-in meetings and just ways in which you can gain access to people who will talk to you in their offices or otherwise, right, to find support. And I think that's super valuable. Talking about whether or not you're a fit and processing through that with somebody is also important. I think that's very difficult to come to because one of the things that I often try and explore is how far should we push ourselves into a level of discomfort for personal growth, as well as how far should we push clients into levels of discomfort for their growth, right, and things of that nature. But I think there's something beneficial just about the whole process and the authenticity associated with the emotions you may experience in those moments. So don't try and suppress your being.
But I think it's going to happen. I mean, I think that there's also that, I know that I've worked with some folks that they thought that was a glitch or a bug. It's like, no, that's the whole program. Like you're gonna show up. It's going to stir things up for you at times. That doesn't mean you're doing anything wrong. That doesn't mean you're a bad therapist. Doesn't mean you're a bad person. It just means you are a person. You just happen to be a person with feelings and thoughts and react. But I think I've worked with quite a few folks, and even myself included. I can still remember a time where I was like, I shouldn't be feeling this way, or this shouldn't be like. No, if you sit with someone and talk about the worst day of their life, or the worst thing they've ever done, or the most painful part of their story, or their deepest grief, or their worst fear, like, yeah, it's going to suck. It's going to suck, and it's going to hurt, and you're going to leave, and you might, I always go back to it, because when I started, I was in all these different clinics. So I did our forensic program, and I was in Lancaster, I was in Lebanon, I was in Harrisburg, and I was in Carlisle, and I just kind of drive all over, and that was and so I cried in my car a lot. I remember many, many days leaving that clinic at 9 p.m. and just driving home an hour and some change, crying about the story I just heard. And like, this is so fucked up, blah, blah, and what do you do with this, and yada, yada. And I guess as a supervisor, where I often challenge myself is, how do I support my supervisees in developing the level of professional distance I now have in the absence of those extremely painful and uncomfortable moments? Yeah. And I don't know. I haven't solved the riddle. I think I can now do I don't cry in my car almost ever now. I mean, it's very rare that I cry in my car. It was like a multiple time a week experience back in the day. Now it's like once a month, maybe. I don't know how to get you here without that road, though. That road of crying in your car. Yeah. Y'all have another way? No.
Just doing it.
Just doing it.
Right. And being willing to have that experience. Like,
yeah, willingness.
There's no linear pathway to becoming a good therapist. Like, you're supposed to like stumble and fall flat on your face, and somebody's going to pick you back up. And as long as you're willing to learn from that and willing to have those feelings, the uncomfortable feelings, anger, sadness, you're going to be okay.
And to create space for that, like not have that reactive, like something's wrong, something's broken, it's a glitch. Right. I need to.
And honestly, if you're not having some of those reactions, I'm a little concerned.
Very concerned.
And let's have a conversation.
Right. Yeah.
Especially if you're under my license.
Let me check you for a control panel.
Yeah.
You know, like. Yeah.
And I think those worst days, I think taking some time to make sure you're also okay otherwise, like you're non-therapist, like, do I need a snack? Do I need a nap? Do I need, like, is life outside of work gotten big right now? And so that's having me have less resources in here, right? Like, we're human beings that sometimes we show up to work with a limp. We show up to work with, it was just yesterday, for whatever reason, Sunday night, I slept 0 minutes. I just couldn't, I was up the whole night until yesterday. And I'm floating through my day yesterday, and my plan is to get through today. I have no other grand optimistic moments for me. It's just today is about just enduring what is and showing up to the best of my abilities in this space, rather than that bigger, I need to fix it. Sometimes you just need to tolerate it.
Mm-hmm.
I think developing your own rituals for being able to have a little bit of separation of the work versus personal life.
Yeah.
It's being able to leave work at work, not have those clients follow you home figuratively, hopefully not literally.
Hopefully not.
Hopefully not, because then again, we have another problem. But yeah, being able to find your ways of what works for you. It's a little bit harder when you have some of the mobile things, family-based MST, all those sorts of things, when you're telehealth and you're working out of your office space in your house.
Yeah.
It's a little more difficult to develop some of those rituals of I'm leaving this here and I'm going now into my own stuff, my own personal life. But finding some of those things. And I know for me, it's just, I have a certain spot where I keep my bag next to my little light that's on my desk. So it's like getting my bag, taking a deep breath, turning out my light, make sure I have everything I need for the day, turning out my other light, giving kind of a once over the room, taking another deep breath, and I'm done.
Yeah.
It doesn't mean that sometimes the clients mentally aren't in my car with me on the way home, but then I have different things that I do when it is one of those days, where it's coming along home. So it's finding what works for you.
There's a lot of boundary shaming in our field surrounding that. Like, you should never think about your clients outside of work. And I just think that's bullshit. I don't know. I mean, I think about my clients in the car. I think about my supervisees and my work. Because I love my work. I love what I do. So of course I'm going to think about the things that I love. It was funny. I was talking to I just got back from vacation last week, and I was talking to some of my coworkers yesterday about this. I'm writing a book, so I was talking to them about the book that I was working on while I was gone, and they're like, "So you didn't take any time off?" And I was like, "But I did. I enjoy this thing. Like, this is a fun thing. That's a not fun thing." And look, I'm tan. This is the tannest I'll ever be. I was outside a lot. I worked on a book outside, which was really nice. You know what I mean? Those kinds of things. But I think there's a lot of like boundary, and I think it's important to have boundaries. But I also think then we pick that up and we feel bad, like, what's wrong with me that I'm thinking about these clients, and and we sort of then develop a new narrative about ourselves, or this work is hard and it's my fault because I won't stop thinking about my clients, and we take on things that aren't ours to carry. And I think if it's not causing you suffering, I think it's fine to noodle over some of those things during non-working hours. I mean, I read therapy books outside of my working hours. Why wouldn't I then also consider the clients on my caseload to whom I can apply these technique books to, or whatever? That's not inappropriate. So why would it be inappropriate to? It's normal. So one of the questions that was submitted for today that I thought was a good one for our conversation, and if you have any questions for the How to Be Happy Hour, you can submit them to Kim at howtobehappyhour.com. Some of our upcoming topics, we're going to do one on family-based mental health services. We have one coming up on origin stories and what drew people into the field in the first place. We have one coming up on multisystemic therapy, MST. So we have that one coming up in a couple months. So we're recording quite a few. If you have any questions, Kim at howtobehappyhour.com. But one of the questions that came up that I thought was an interesting one is, what has changed about either the way you think about therapy and your role with clients over the course of your career, sort of the conceptualized, the idea of what a therapist is and how change occurs. How has that evolved over the course of your career?
I think I see it now as a much more active role. I think I tended towards the more passive anyway, because that's just my nature. So maybe that's why I happen to see it in that lens as well. But I see it now as a much more active, like there's a lot more going on in the room. It's not just the analysis of all the things and like, oh, there's all the things. Cool. That's what it is. And then nothing it's all the interventions and the moving forward and the activity and the being deliberate about the direction that you're heading and all of that kind of thing.
I think not giving an answer for every like problem that pops up. Like there's not always like a reason behind something. Like somebody could just be crying because they just need to cry. I think when I started my career as a therapist, it was, oh, well, they're doing this. Maybe there's a reason why, like they're sitting a certain way. But it's just at the end of the day, you think back, like I don't even have solutions for everything that I experience. So why do I put this on to this person just because they're in mental health services? So I think, again, going back to that rescuer complex, like sometimes things happen just to happen. There's no reason behind it. There's no explanation that needs to be done. There doesn't need to be a diagnosis slapped on every single thing that somebody, it's like some emotion that's going through, like, oh, you're feeling this way, you must be depressed. That's not always the case. So.
Yeah, kind of building off that, a joke that Roy will bring up every once in a while I'm talking to him is that I'm omniscient because I wanted to know everything. I want to have the solution, the answer to every problem that exists. And that's not obviously reasonable. You're not omniscient. You cannot become it either. And if you can, tell me how.
I had to change the way that I looked at progress.
Yes.
When I first started, it was very rigid. You know, if client is doing X, that means that they are succeeding in therapy. Therefore, I am a great therapist. But in reality, change is really freaking hard. And it is sometimes like a several years long process. So like we have 45 minutes of somebody's life a week. Like, what are you really going to do with that? So having to change my view of progress, even being just like this very small thing where somebody advocated for themselves even a little bit, that's a win.
Yeah.
Yeah.
I think what struck me over the course of my career is I like the nonlinear development piece, but I think it's also how much the job is changing me as I'm changing it or as I'm changing them. And I don't think I saw that at all when I started. I think I had no idea how much the ability to bear witness to somebody's deepest point of suffering, like so many moments where I'm sitting in therapy and I have that insight or aha moment, or I have that like deep, like that connection to that deep sense of gratitude, or I notice something in one of my own important relationships that I'm seeing within this relationship that's playing out in the room in front of me, or I notice a dynamic that occurs between me and one of my kiddos that I'm seeing within this caregiver and this child. And I think that I didn't see that when I first got into the field. Like I knew that like me search would happen along the way, right? But I don't know that I knew in the 21 years that I've done therapy, I realized how different I would be because of it too. And I know that today, I started college for art. I wanted to be a fine art photography major. And I know today I'm a significantly different human being because I became a therapist versus I became a photographer. I would be different today in my relationships and the work that I do. And I think so often the work is never about us and it should never be about us. And if we notice ourselves in the therapy room making it about us, that's a great conversation to have with your supervisor. And you are not immune to it. Like when the therapeutic process is taking shape, it touches everyone within the room and you are included in that. For good, for bad, for all the things. Does anyone have a difficult client story from your career early on? One of those clients that, for me, the one example is that gentleman that I talked about, the suicidal client and the fit. That is just one of those like, aha, once I saw it in my career, I could never unsee it. Do you have any similar client or therapeutic experiences that you could tell in a de-identified way that has impacted or shifted the work that you do in a way that was noticeable?
I have one. So there was a client I was working with, and this kind of goes to that idea that, you know, I wanted to implement a very structured theoretical approach, and I wanted to see the progress and, you know, the way that it was told to me and the thing I was reading that it would show, right? And So in working with this very depressed client who at times will become suicidal, I was attempting to kind of force things into these blocks, and they were resistant, right? And my continued pressing to try and fit things into this formed thing that just wasn't working increased resistance, and actually probably hurt the work I was doing with them. And ultimately, they didn't die, thank goodness. But in my supervision and continuously like talking about, I'm not getting where I need or want to be. I think that was what helped open my eyes. I don't think it was just overnight or even just over that period of time working with that client. I think there were multiple things that helped really shape how I think about it now. But I can't do that, and it doesn't look like that. That's not how this works. And I think that was difficult for me to understand at the beginning because I wanted things to be very straightforward, or at least that would have made it easier for me at that point in time.
Well, it sounds like in that space, the therapy became, at least to some degree, about you a little bit, or like your expectations, your needs within the therapy room was that you wanted therapy to fit into this box. And I mean, I think that's one of the hardest parts about being a therapist is taking your own values. You have to kind of put it on a shelf to some degree and meet this client where they're at.
Well, and it wasn't so much that I wanted that. It's that's what I believed successful therapy looked like, right? Because, again, my frame of reference was this step-by-step thing that said, whenever you do this, this will happen, or this should happen next, and that wasn't working, right? And so I'm not being successful. I'm not doing it correctly if it's not showing like this, right? But that's not realistic, again. That's not how that works.
I was thinking of this case earlier when we were talking about being fired, because ultimately I was fired from this case. But that was one of the moments that I think really solidified a lot of things for me, kind of like a pivotal moment in the way that I do therapy, I would say. So, background that's important. I started in family-based. I already said, like, I tend to be a lot in my head and don't speak very quickly because things have to be spoken in a certain way. And also, I come from a family where conflict's not a thing. Not a thing. It's just avoided like the plague. So when conflict comes up, which in family-based, it comes up a lot, like there would be almost like a shutdown because also I'm going to that space in my head because it's very comfortable there and there's chaos out here. So I did a lot of work on that, had a lot of conversations with my family-based partner about like, hey, look, I want to be here for you. Because she was also noticing like, hey, I need you in these like crisis moments. Like you can't just check out. I was like, I get that. So did a lot of work coordinating with that, which also allowed me that safe space to be able to try some of those things with her support as well, because she had been doing it already for a while and lots of things. But anyway, so we had this case. We had some things that the child who was our IP had told us about that needed to be childlined. And the way that we usually function is that we let the parent know, like, hey, by the way, we have some things that came up. We have to make this report because we're mandated reporters, blah, blah, blah. Like, do you want to make that report with us? No. Like, that's totally fine. Oh, okay. We'll go make our report. So we went and made our report, and apparently they called, and the family was not very happy with some of the things that CYS had told them whenever they called. We had no idea any of this took place, so we show up to do our treatment plan because it's due, and that's what's what we got on our agenda for the day. We're walking up there to their porch, and my partner happens to get a phone call from one of our other families that we've been trying to get a hold of. So she's like, hey, I'm going to take this. You go ahead and get started. I'll be in a minute. Cool. So she walks around the corner of the house just to take the phone call. I go, knock on the door. I don't even step foot over the doorway. Mom's standing there screaming, yelling at me. All I want to do is just go in my head and retreat. But I didn't. And like what I did, I was able to respond to her concerns in a caring, loving, therapeutic, boundary appropriate way of like, hey, we did tell you could be part of this phone call. We already told you, like we didn't tell you anything different than what we told them. you know, and was able to be there and be supportive and like maintain that boundary of like, no, we stand by that we had to make a report.
Yeah.
It's part of our job. But they weren't happy with it. And they, you know, you're never welcome in our house again, blah, 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 blah. Sorry to hear that. Okay. My partner comes around the corner from her phone call. The door slams in our face. And I'm like, all right.
Just got a free afternoon.
Yeah. So like, hey, we're not working with them anymore. But for me, it was that moment of like, hey, look, I did it. Like, I didn't go into my head. Like, I stayed present, and I feel like I gave her good therapeutic feedback, you know, in the midst of her being very dysregulated. And so that was a turning point for me. And because, I think especially because it ended poorly,
Yeah.
I had that confidence. And after that, like, I could say this when this client is regulated and just looking for feedback, and we have a better relationship maybe than what this other one had, because I don't know, she wasn't engaged the whole time. But it allowed me to be able to say those things more readily, and to build some of that confidence in being able to do that.
No, I think that doing the thing and then trusting your own experience in it, I think is super important. I was interesting when I was thinking about this question for myself. I think there's a lot of clients that have changed me over the years. A lot. I mean, I can say like pretty definitively there are quite a few clients, supervisees, colleagues, coworkers that over the course of my career really shifted some things for me. But I can think about one client in particular that I don't know. I just cared about this client quite deeply, and we had an interesting therapeutic relationship in that it started and his therapist was leaving, and so he was pissed about, you know, like that process. We've all probably done that at some point in time where you're now the substitute teacher turned like long-term sub, or you're now there forever. And so he like hated me at the beginning and told me to fuck myself. And he was also having like 30-minute sessions with his previous therapist. So he's trying to like leave our sessions halfway through them and that sort of thing. So we had to unpack a couple, like we had to fix a few different things along the way. But I think what I took from that experience and several others, ultimately, at the end of the day, this client died by overdose. After working together for a really long time, coming out of an inpatient, working with him in outpatient, he was successful in outpatient for many, many years. And then he had a medical procedure, was prescribed pain management following his medical procedure. And he was pretty quickly off to the races after that. And I think died fairly shortly after that. And I think what I got from that, and I don't have like a fully formed idea. My train is not even on the tracks. I don't even know if it's a train at this point. But is that like the worst client outcome might happen over the course of your career? And I think that was the first time. And I had lost clients I had a client die by suicide very early in my career, but it wasn't a client I was very connected to. There's a lot of distance there. I hadn't worked with him very long. There wasn't as much intimacy in that space. But is that you might have like the oh shit client situation where you're brought into contact with your clinical grief, where you have to, you know, bury a client or sit with a family. I know in family-based, sometimes we do the work where we sit with the family following the suicide of the child or adolescent. And I don't know. I think there are just days, and when I'm thinking about this client in particular, that was the day where it landed. Like, you're going to love these people, you're going to care about these people, you're going to be rooting for them and in their corner, and just and there are going to be days where the worst thing happens. And that doesn't mean that your work wasn't valuable along the way. Even because when I reflect back on this gentleman, like the day I met him, he was living in an abandoned building with a bunch of cats, very sick medically. He had a lot of complicated medical issues. He's not been high for a very long time. And by the time he died, he had an apartment. He had been reconnected with his estranged son. He, you know, just sort of had some of these experiences that wouldn't have been present had we never met. And even though he still died by overdose in the end, that doesn't mean that the time in there wasn't valuable along the way. It was a very long and rambling place to get there, but that was the story that really showed up for me. So we have another great question that was submitted that I thought was really interesting. And it was, and it's one of those that says, feel free to rephrase. So I need to make sure I phrase it in a way. So I guess the question is, how do we as therapists navigate our personal relationships that are not therapeutic? And so this question specifically asks about couples in which one person is a therapist and the other is not a therapist. When you have conflict within the romantic dyad, is it appropriate for this person to use technical therapeutic jargon or whatever? And it made me laugh because I remember when my husband and I first met, he would get really mad at me for using my therapy voice. And what I soon came to discover is that therapy voice, that was my regulated voice. That was my voice when it was like, I want to fucking lose my shit in this moment. But instead, I'm just going to say, and what do you think about that? Or whatever it is. That's when I realized that I couldn't separate those two things. But what have y'all found that early on? How do you navigate that you are a therapist and you are a person, and the therapeutic relationship is a relationship and is intimate, but shouldn't maybe necessarily go into your personal life? For those of you with partners, do you use therapeutic jargon when you argue with your partner?
I think we had a similar conversation that you had, because when we were dating in college, I was a psych major. It was in undergrad. It's where we met. And we had a conversation pretty early on in our dating relationship. He's like, I recognize that you're studying this, but you can't therapize me. We're not going to be able to date. Okay. I'm not planning to. That's not part of the process. And so that has come up during, disagreements here and there of like, are you therapizing me? Like, no, that's not what's happening here. There's pieces of me that are coming out that may also help in the therapy room, but it's not, it's not therapy jargon. It's not strategies or technique. I mean, I'm trying to use assertive communication skills, but I mean, everybody should use assertive communication skills. So but it's not.
If we all walked around with our DBT handouts, the world would be a better place. I don't understand why you're mad about it.
Yeah. So little bits, but not too much.
For me, I often, because that's how I know how to articulate my experience. Like those are the phrases, that's the language, that's the terminology. And I know certainly, like as a parent, I very frequently call upon some of those pieces. As a parent, I very frequently, like if my child is losing it, it's like, well, let's do a grounding exercise, or let's do this, or let's do that. That's not me doing therapy to my child. I know a skill. It is my job as their parent and caregiver to teach them a broad range of skills, everything from like how to pay your credit card bill to how to navigate really big feelings. I see all of that on the continuum of things we need to learn as a human for them to go be humans out in the world. So of course, therapist Kim will show up there sometimes.
In my last relationship, we would talk about this every once in a while. I think what often came up when the idea of like me therapizing would come up, right? It was really just what was really being communicated was that I was making them feel like they were or had the problem and I did not, right? And so I was kind of externally from the relationship attempting to solve the problem.
Which was them.
Right, which is what they were feeling in that moment. I think figuring out and addressing that, right, was the most like helpful thing to do. So
I think also checking yourself and what your role is in this relationship, right? Like in my marriage, I can't try to be a therapist to him. He's got a therapist. He can go hang out with him. Like, I'm in this with you. If we're having conflict, we're navigating that as a team.
Yeah.
For this to be effective, there can't be that power imbalance. And if I'm showing up as the therapist in this, then I have the upper hand.
Which is exactly what I think the other person was experiencing.
See, it's interesting because as you were saying that, I was really thinking my husband is the problem in our marriage, like always. It's always his fault. And so I think it would, no, not at all. But I think there is that thinking modality. But I don't know, like like you talked about, like these are parts of myself that help me therapy. Like there are also things that happen fairly organically or not. Like I worked for a while in a research lab where we watched interactions between parents and caregivers and children, and we would code them on the basis of attachment. I did that hundreds of times. I can't not see that sometimes. Like I can't not see if I'm in this place that every once in a while, like, wow, that mom just left and the child lost their shit. But then when the mom comes back, the child also loses their shit. Feels like avoidant attachment to me. There's certain things you just can't unsee once you see them. And so how do we do that in a way that is safe for our other relationships, I suppose? I think power is one of them. Or safe for us. Because it's also not safe for us to clock out and then become our friends' therapists and our aunt's therapists and our cousin's sister's best friend once removed from college, hairdresser's mental health consultant. Like, but so often there is that idea of, oh, you're a psychologist? Let me tell you things. I had a guy do it in the beer line at the Bears game last night. Oh, you're a psycho. Well, how do you make sense of this? Oh, man, random drunk stranger. I don't know.
I think it's tough when it is our friends or family members that are going through some of that stuff, because even if you weren't a therapist, they would be turning to you with some of these things of like, here's the thing that sucks right now in my life.
Yeah.
And I need your support as my friend. And I think, and I have a friend that recently went through some very sucky things. And was helping just to be there for her. Most of it was just letting her talk, but she's also been super engaged with therapy. And so then she would also bring into our conversation of like, hey, here's what my therapist told me, and this is the insight I got, and like, you know, all the things. And so it was trying to keep the space of like, okay, yeah, I really like your therapist. You got a good one.
Yeah.
Like, you know, but also like, okay, how do I support but not therapist? And having that be an awareness of myself.
Yeah.
But also support all the really good insights that she's having, but also talk about like, hey, yeah, I notice this happens for you sometimes. And, you know, but that coming from a space of our friend interactions of us hanging out, not the moment of that conversation. So it's tricky because there's a lot of overlap, right?
Yeah.
I think an interesting dynamic that I've had to deal with more commonly is that people will stop talking to me about things that they have problems with. And not because they feel like I'm going to psychoanalyze them in some way. They'll just say, I know you're not my therapist. I know that's not, I know you don't want to hear about my problems because you hear about them all the time from other people. But, right, and so kind of talking about our relationship existed before and we were able to talk about things that stressed us out. It can definitely still exist in that capacity. And I'm not going to psychoanalyze you, and we're not going to have a 45-minute session. Like, that's not what happens. Our relationship is the same. So,
But I mean, I would say I also use some of the same phrases or like some of the same sentences come out. Well, how do you make sense of that? What do you think's going on? Like,
right.
and those are sentences I use in supervision, I use in therapy, but I also use as a like, how do you make sense of that? I'm curious.
I think anytime that I would ask about family or something like in that regard, that might come up too. And it's only happened maybe once or twice with certain, and usually it's not my super close friends. It's kind of friends that are a little bit further away, but they'll ask, right, is this therapist Eden asking this, or is this regular Eden?
Yeah. I think it kind of goes into that stereotype that people that work in like the therapy world or the mental health world, like, this is our identity. Like, how do you have failed relationships, failed friendships? How do you have strained family? Because, you know, once upon a time, I wasn't a therapist. Like, yes, this is my profession. This is a part of me, but it's not me. You know, like, I get angry too. Like, that's my, like, when kids come up, they're like, you never experienced. I was like, believe it or not, I also get angry. Like, I also get frustrated. Like, I also sometimes feel like I want to punch a wall. Like, I'm not a robot. So I think too, people put on these expectations of us that, you know, like, oh, I bet your communication's like perfect with everybody and you have the answers to everything. And it's like, no, sometimes I have no friggin' idea what I'm doing. You know, like sometimes I don't even remember like what I wore yesterday. So I think sometimes too, we get like, we're like the problem solvers of the world. So like we have to have like these perfect personas of you can fix anything. So
I think we hold ourselves to that standard.
Oh, for sure.
Too. I mean, I work with a lot of early career clinicians that are like, well, how am I supposed to help them if I can't help me? Or I've got to get all my shit together. I have to be completely put together and perfect in every way possible to be able to help somebody else. And I don't know, like, I think the imperfection is what makes it work. Like it's the humanness in the room is what makes this an effective process. And it wouldn't be effective if you were perfect. Because if you're perfect, there's no, how can you connect to somebody who's glossy and just perfect all the time? There's no authenticity there.
Yes.
There's no genuineness there. And so I think that's but we have that expectation of ourselves. And like, you know, sometimes we can get by with like broken tools work sometimes. I don't know. And I think we're all going to be a broken tool every once in a while. So kind of our last question, what resources, books, courses, what would y'all recommend to somebody starting out in the field, just getting going, not sure about their next phase? What would be some suggestions you would make for those early career clinicians?
Don't listen to what anybody says on TikTok. There's a lot of self-diagnosers out there. I'm not saying people's experiences aren't valid. They are. But I sometimes find myself like going on TikTok and someone, because they're wearing like a suit and tie, they say something and it's like, and then I question myself and my values and what I learned. And I'm like, why am I listening to this random person on TikTok? So I definitely think like, social media is a great thing, but it's also very detrimental in this profession.
I'm struggling to think of the author, but there's a book that I have in my office, Clinical Social Work Theory. And it's funny, Crystal Porter, it was her book from a long time ago. And that book is like the Bible I keep at work. It like it's just chock full of all these good things. So if you look hard enough and you can find that is the tool I utilize when I'm really struggling. But there are so many good books out there.
Rosenthal's Encyclopedia of Counseling. I mean, obviously for studying purposes, but it's so good. Like you just, if you kind of forget what to do or trying to explore other types of like therapy theories, it's a good source.
Yeah. I think for me, it's pick one. Like, I think that there are so many great tools, great resources, like even sitting here, like I could give you a list of 50 books you should read, but I'm struggling to come up with like the one that I would recommend. But I think to try some things out, and I think one of the best ways to become an effective therapist is to go to your own therapy and pay attention to what works and doesn't work for you. And then the things that really seem to land for you are likely the spaces in which you will be the most effective implementing those for others. And so if you notice that, if you've had that experience, if you've been in your own therapy and your therapist has done a particular intervention with you and you're like, oh my goodness, mind blown, maybe figure out what theory or model that intervention came from. And I would say that's where you begin. And I mean, for me, I'm fortunate in that I'm trait obsessive. So I get my special interest. Once I have a special interest, like I want to learn everything there is to know about that thing. And so that is a personality quirk that doesn't serve me in a lot of other zones. But in becoming a therapist, it was extremely beneficial because I read about, I think, what was the acceptance and commitment therapy was one of the big ones. I read about ACT and I was like, holy shit, this is amazing. And then I read everything about ACT. I read every book written by, Kelly Wilson, Stephen Hayes, Russ Harris, like every single, just voraciously became obsessed with it. Practiced it with all of my clients, brought it up in supervision over and over and over again. And I think getting really good at one model If you can do nothing else, pick a model. And it doesn't mean you can't ever shift. That's why I love family-based. I think pound for pound, every clinician that starts as a family-based provider that goes into any other role, if you have that therapeutic orientation, that theoretical underpinning that you spend 3 years like learning and developing and practicing and record yourself. That's another one. It's an aside, but that's another one. I have so many supervisees. You don't. You're great. You always record. But I have a lot of supervisees that are like, I'm not going to record because that makes me nervous.
You become comfortable with like looking at and
Once
talking
you
about
do
your
it.
issues. Yeah.
Yeah. Well, once you do, and I don't know. I don't know if I'd be the therapist I was today if I didn't have a setting for 5 years where every single one of my sessions were recorded and my supervisor could look at any point in that session. I mean, that to me was the secret sauce. But I think get obsessed, learn something really deeply, and then grow from there.
Yeah, David Burns. So when I started, I feel like a lot of supervisees I've had and just people I've talked to that graduated in the recent past, cognitive therapies are a lot of what I feel like I hear people learn about. He wrote Feeling Good. So I read that book when I started. So if you're interested in cognitive-based therapies, that's a good introduction.
That can be a helpful one.
Yeah.
Gosh, Man's Search for Meaning, Viktor Frankl was a
that's a
big
good
one. I know that Yalom has a bunch of really good ones. Love Executioner. Gosh, there's just so many. But I mean, for me, I think probably my most seminal one, Things Could Go Terribly, Horribly Wrong by Kelly Wilson, I would say was at the top of my list.
I forgot about that one. That was a good one.
I've only read the name, and so I might butcher it. So the attachment therapists would hate it, but Bowlby.
Oh, Bowlby.
Bowlby, yeah. There's an attachment in adulthood. Yeah, those are good.
Yeah. Gosh. So there's a lot of really amazing resources out there. But I think those would be the big points of advice. So as we wrap up, is there anything left unsaid? Any pieces, any things that we didn't chat through that y'all feel would be remiss if we close this space without addressing it?
I think one thing for myself is my advice is if you 5 years down the road are the same type of therapist that you were on day one, that you did not grow. I think if I were to look back at myself from 2020, I probably would cringe. I'd be like, why didn't you do that? Like, it's just like I mean, I feel like even this year, like this is my most growth as a therapist, and I can't wait for like my adventure to continue and as I go into different things. But I feel like if you're not learning, if you're not shifting things that could go good, could go bad, like I think if you don't have any personal growth, like you're not doing this right.
Yeah. I would agree. I think if you're not uncomfortable, if every day is easy and you walk out feeling like you nailed it, and your clients never follow you home, metaphorically speaking, and you never make a therapeutic mistake, and you never miss a session or late, or you know what I mean? Like, I think that's where the growth is. The growth is in the discomfort. And I think our window of tolerance is often a lot bigger than we think it is. I think we often believe, I can't do that thing. And then we meet the thing we didn't think we could do, and we come out the other side of it, and we discover, oh, wow, I can. But we only do it through tolerating the discomfort along the way.
Yeah. Every therapist at some point did not know what they know currently.
Yep.
So push yourself into that discomfort, because everyone had to get there, had to go through it to get where they are.
Somehow.
Yeah.
Don't let fear stop you from having the difficult conversation, whether that's with your client or if that's with your supervisor who said something that really rubbed you the wrong way. Go have that conversation. I know for myself, like in these last few months, that's led to the most growth I've had this year, right? And just really admitting a lot of things out loud to myself. And I've been off to the races ever since. So there's a lot of value in having these tough conversations.
I think in recognizing too that imposter syndrome's a thing.
Yeah.
That's gonna happen, and it's gonna get better, but that doesn't mean that your growth stops. You know, you feel more comfortable, you find your your balance as a therapist and your style and your thing. But you're still learning and growing. There's always going to be something new. There's always going to be like a new type of client that comes in that you're like, I have not seen this before and I don't know how to respond to this. All right, supervisor, what do I do now? What can I work on with this? So there's still things that, I'm learning and growing with all the time. It's new types of challenges, it's different things, but it's always growth, and imposter syndrome still comes up every now and again.
Oh, for
Not
sure.
nearly as much as it used to, thank goodness, because I don't know if I can tolerate that. But, it still comes up every now and again.
Oh, I like that. And when I think there's that that acknowledgement of imposter in sorry, I need to clear my throat and we'll just edit this out. Okay. There's that acknowledgement about how regardless of however long you're in this career, you will come into contact with all those same pieces over and over and over again. And so you mentioned imposter syndrome, and I know that I navigated it as a student, right? And then I wasn't a student, and then I had to navigate it as a therapist, and then I became a supervisor. And then on top of my role as a clinical supervisor, I also have to make leadership-based decisions where it's like, wow, I have to make a choice that impacts a 700-person company. And both of my options aren't great. And there will be criticism and there will be negative feedback, and I'm going to piss off at least half the people, right? So what choice do I make in this place? And I think that imposter syndrome is going to show up in different ways. That pot stuff where we started this off at, which was like, oh yeah, pots will show up and you'll work, person of the therapist will show up and you'll work through it in supervision and you'll talk about it in your consultation, and then it will be less big. But if you move into a different role or a different setting or even a different type of client or presenting problem, it's probably going to show up again, just maybe with wearing a different face at that time. And so recognizing that, again, development growth is not linear, that it's just this pattern of cycles, this synchronicitous journey we're all on. Well, then, I want to thank you all for coming, joining, and sharing the space with me. We do have a couple upcoming podcasts. So we have one on origin stories and what brings people into the field in the first place. We have one coming up on family-based therapy and what it is. We have one coming up on multisystemic therapy and what is that. And then we also are working on we need a lighter topic at some point. So we've been doing some real heavy ones. I'm ready for like a murder shows or Christmas movies or something. So we'll probably go that direction at some point. But please email us, Kim at howtobehappyhour, if you'd like to submit a question for those. And otherwise, thank you terribly much. Bye.